Can I get everybody's attention? We are jammed. We have got a really great agenda for the rest of the afternoon. And I would very much like everybody to quiet down for a few minutes so that we can get started, because it's a really full agenda. Thank you. So I hope you enjoyed lunch, and now we're going to switch topics a little bit, and we're going to talk about cancer prehabilitation and rehabilitation, things that can be done before and after treatment to help you out. We've got wonderful experts here. Dr. Sarah Sutka is an associate professor of urology at the University of Washington. She's a leading expert in the management of non-muscle invasive and muscle invasive bladder cancer. Some of you probably are her patients. She serves as the leader of the urologic program at Harborview Medical Center and is the associate program director of the UW Society of Urologic Oncology Fellowships. And she is the director of the UW Society. Oh, I already wrote that. I already said that. I'm sorry. I put it in there twice. Her research is dedicated to personalized risk stratification in advanced urologic malignancies, integrating aging principles, comprehensive geriatric assessments, body composition, psychometric assessments. She leads multiple clinical trials, including one that I will say was funded by BCAN at $1.5 million, and she will be sharing her research with you, which is now in its second year. It's very exciting to have her here. She really does focus a lot on aging, so she's thinking beyond just your general urologic issues, but the whole patient, again, thinking back to what Dr. Gore was saying about patient being center of everything, and this has definitely played out with the team here. She's joined by Dr. Hannah Hunter. She's a board-certified physician in physical medicine and rehabilitation. She's the medical director of cancer rehabilitation at the Fred Hutch Cancer Center and associate professor in the Department of Rehabilitation Medicine at University of Washington. And she specializes in the diagnosis and treatment of musculoskeletal and neurologic changes that can occur from cancer and treatment. And they're joined by Dr. David Shepard, who is a clinical neuropsychologist and assistant professor in the Department of Rehabilitation Medicine at the Fred Hutch Center. He graduated with a degree in clinical psychology and neuropsychology at the major at the University of Houston, and he's interested in helping patients who are experiencing symptoms and changes in cognitive function that affect their daily lives, especially in the cancer space. So their talk is really going to be what you can do before treatment, how you can bounce back after treatment, and how all these treatments can impact you. And I'm going to turn it over to them and turn myself on mute. Save questions for the end. And as we get there, I'll ask you to come up to the microphones and ask your question there so we can all hear it. That'll be much easier.
All right. Well, good afternoon, everyone. I have to start with, and I want to thank Stephanie for that very kind introduction, and thank you to BCAN and to Diane and everyone for bringing us all together for this today. I have to give kind of a personal just thanks as well, because as Stephanie mentioned, what you're going to hear about is something that I've thought about for a long time. I thought about it in medical school, I thought about it during residency, I thought about it in my first job in Chicago, and I wanted to study it. But this kind of work is actually really hard to find ways to do, because it's a little out of the box, and we'll show you some of it. But BCAN, from the very get-go, because of its patient-centered force, got in my corner. And a lot of the work you're going to see has been funded by this organization, has been given a platform to succeed because of this organization directly. And we're just really excited to share with you what we've done in the last couple of years, sort of building on that. So we're going to talk about cultivating resilience, which is one of my favorite topics. I have a couple patients in the audience, and you all know that I talk about this a lot in our visits. So this is really kind of a little bit of the science behind it, and then we're going to really get practical about how we can build resilience across the spectrum of survivorship. So I am so lucky to be joined by Hannah and David, who are two incredible colleagues and collaborators in the clinical space, but also in the research space. And I know you're going to really benefit from what they have to say today. So without further ado, we're going to kind of jump in. So here's our roadmap. The problem here, of course, is that we're talking about bladder cancer, which is a disease that affects us, a patient, in all realms of their life. And I want to actually take a few minutes and acknowledge just how much this disease affects all of us. It affects a patient from the physical standpoint, from the mental standpoint, from the psychological standpoint. It affects the people around them. And if we don't pay attention to that as care providers, then we are not helping you to have the best possible outcomes you can. And so that's what we're going to focus on. Then we're really going to get into this concept of resilience. We're going to define it. We're going to talk about why it's important. And then we're going to give you some very concrete strategies for how we can cultivate it. We're going to focus here today. There's a lot of ways to cultivate resilience. But we're going to focus on the physical and the cognitive. So let's talk a little bit about how this cancer affects our patients. So I'm going to go through mostly kind of a disease stage specific reference list. This is not exhaustive. For all of you who are patients in the room, I'm trying to draw attention to some of the symptoms that you may face, but everyone's lived experience is different, and I acknowledge that. But the fact of the matter is that non-muscle invasive disease, muscle invasive disease, and metastatic disease affects patients in very substantial ways. We know that patients with non-muscle invasive bladder cancer have symptoms related to the cancer in their bladder itself, and that can affect things like hematuria, blood in the urine, difficulties with urination. But also, non-muscle invasive bladder cancer and its treatments can increase fatigue and pain, and that's really important. And as we all know, in the best scenario, when I meet someone with non-muscle invasive bladder cancer, I say, my goal is to turn this into a chronic illness, something that unfortunately we may never make it go away because there's always going to be something that we have to deal with it. But if we can turn it into something that doesn't affect your length of life, that's a win. And then my job is to try to reduce the amount that the therapies actually impact your quality of life. And so that's what we're talking about here. Muscle invasive disease and the treatments for muscle invasive disease impact patients in a number of ways. And we know that the surgery that we ask patients to go through to treat muscle invasive bladder cancer has a myriad of effects in the short term and the long term. Because it's a surgery with a lot of moving parts. It's a cancer surgery where the bladder and the surrounding organs and the pelvis are removed. It's also a major reconstructive procedure, and a lot of the long-term side effects of the surgery are related to how that reconstruction weathers over time and how we learn to live with that new reconstruction. So there's significant cosmetic considerations as a patient's body is changed by the operation of having the bladder removed and having the new reconstruction done. There's issues, obviously, that can arise with the wound healing, but also with the way the stoma and the ostomy recovers and lasts over time. Obviously, how urine exits, now we have this absorptive surface that's supposed to be absorbing your nutrients from your food, and it's sitting next to a waste product. That has implications for nutrition, your vitamin absorption, your acid-base balance, all of which can impact things like bone health, renal health, and all sorts of other aspects of your life outside of your urinary tract. And so that's pretty substantial. And I think something that we don't talk about enough, and that as surgeons it's really important that we talk to you about and that you feel comfortable bringing up to us, is bladder cancer obviously affects sexual health. And that's something that's actually very important, and it's something we should pay a lot of attention to. In removing the bladder and the surrounding pelvic organs, there are implications in both men and women for long-term sexual health that are related not only to the mechanics of how things work, but also things like sex drive and just how we feel about ourselves. And I would say that sexual dysfunction is obviously associated very much with sort of the anatomy and the physiology that changes with treatment for bladder cancer surgery, but there's also, we're going to get into sort of the mental health implications of being a cancer survivor and going through the therapies for cancer. And that also can affect our relationships with the people around us, and ultimately how that all kind of compiles to result in sort of a healthy or a challenges within one's sex life. Obviously, systemic therapy for bladder cancer. Let's see if I can get back. All right. Is it possible to bring my slide back one? Thank you. So systemic therapy for bladder cancer, we have thankfully, a lot of options for how we treat bladder cancer using systemic drugs. Chemotherapies, which you can think of them like poisons for the cancer, and immunotherapies, medicines that take the brakes off the immune system so that our immune systems can better fight the cancer. These different types of treatments really affect a patient's body in a number of different ways, and the side effects are substantial. Very, very different based on what kind of treatment you're getting. And a lot of patients will actually receive these medicines in different medications at different times during their treatment pathway. And so you can see here sort of the physical implications of receiving cytotoxic chemotherapy as well as of receiving immunotherapy. But I think one other thing that I think about a lot is how cancer impacts mental health and sort of the lived experience of a patient on a day-to-day basis. Obviously, the moment when a patient is confronted with this diagnosis is a life-changing moment. And I think that ultimately it changes a lot in terms of how patients live life on a day-to-day basis. I have a good friend who works for another patient advocacy organization, and she talks about sort of the cognitive load of carrying a diagnosis of cancer and how that just kind of creeps in and colors thoughts, experiences in ways that perhaps as a provider I can't begin to understand. Distress is a really important side effect of cancer and cancer treatment. This is a multifactorial, unpleasant emotional experience of a psychological, social, spiritual, or physical nature. So this can manifest in many different ways. And that can interfere with the ability to cope effectively with the cancer itself, but also with the therapies. And survivors of cancer definitely, we know, have an increased risk of mental health concerns that can sort of relate to all aspects of how that cancer diagnosis colors lived experiences and ability to receive therapy and sort of enjoy life outside of being a cancer survivor. I think a lot about with bladder cancer, just the amount, the sort of what we call treatment burden, or the degree to which the disease impacts day-to-day living in all ways, shapes, and forms, whether you are without evidence of disease or whether you're actively dealing with a tumor at that time. And obviously, the fear of recurrence is a really important part of that. And that can, as patients come up on their every 3-month cystoscopies or their every 3-month scans, or as patients get further on in their journey and they're actually not seeing us maybe quite so much, those moments when those days leading up to the visit, I hear patients talk a lot about just how much they are anxious in anticipation of potentially receiving some tough news. And that is very important as well. And so we need to be thinking as providers about how we can navigate and mitigate that distress that is so affected with this diagnosis. And this just has to do with the fact that bladder cancer takes a lot of time and energy to treat. And you know this as patients and you know this as caregivers. It's a lot of visits, it's a lot of time getting to visits, it's a lot of time away from your family, your work, the things that you love to do. And we're cognizant of that. So the other thing, though, that I think about a lot, and those of you who see me in practice know we talk a lot about physical function and independence. And this is a cancer that can really impact the way that one lives one's life, the way that they want to. So we think a lot about how these treatments can impact things like needs for new assistive devices or more help at home, help with completing the sort of daily activities of living. A lot of the therapies can make patients less able to do the things that they really enjoy doing, and that's important because obviously that sort of lived experience, the ability to, whether it's as simple as kind of transferring within the home and getting around in your house and making your own food, getting to the grocery store, whether it's more complex, it's maybe traveling, seeing your family who live across the country. This cancer can affect all of those things. And it's really important that we think about how we can help patients minimize that impact so that they can continue to live the best way they can. And this is something we don't have a lot of data about, actually. It's something that I actually have some patients I know in the audience are participating in a study we call the Bounce Back study, where we're looking at how folks recover from surgery in a really detailed, patient-focused way. So we can start to understand and we can start to tell patients, yes, here's the risks of things like cancer recurrence, but here's when you're gonna feel good again. Here's when you're gonna be able to go travel and see your kids across the country again. Because those are outcomes that actually as providers we really need to prioritize. So I've spent a few minutes now talking about bladder cancer and how it affects all areas of life. I didn't hit on everything. You may have had areas of your life that I didn't touch on, but I acknowledge those here. The question is now, though, how can we do a better job of helping you prepare for that treatment, prepare for the impact of this cancer, and how can we reduce the impact of this cancer in such a way that it makes that lived experience better? So I like this. If we say fortune favors the prepared, if we can be prepared, maybe we can have a better outcome. And I believe very strongly that survivorship, and I use that word because I think, I'm going to acknowledge that what that word means, right? So survivorship is everything. It's life from the moment that you hear that word, the C word, the first time, and forward. A cancer survivor is someone who receives a diagnosis of bladder cancer or any other cancer, and it affects all of those patients, all of those people around them who care about them. But I really think that survivorship cares before you even select your treatment. Because if we can think about the long-term outcomes, we can and the long-term outcomes that matter most to you as a patient, then we can design a treatment program that's going to actually best set you up for success. And so I think a lot about education, I think a lot about preparation, and Hannah and David are going to give you some really key strategies to sort of fill your toolbox and think ahead for how to tackle the problems that we can anticipate that are possibly going to come down the pipeline. And then also we want to think about how we can prevent problems. If we can prevent them, that's even better. We don't have to deal with them. So preparing for what's to come. One of the things Stephanie mentioned to you that is a really big part of my research program is what I call comprehensive risk assessment. And I'm trying to think how many years ago it was now. When I first came to Washington, I was lucky enough to be funded by the Young Investigator Mechanism by BCAN, and the program funded my project that was called the R2 assessment, the Risk and Resilience Assessment. And I'm going to show you some of the work that came out of that. But we really think about not just thinking about understanding the cancer. We can stage the cancer. We can talk about the grade, the stage, the type of cancer. From that, we can talk about what the risk-adapted treatment program is going to look like. But I want to know about you. I want to know about all of your resources, the things that make you strong. I want to know about your vulnerabilities, the things that might put you at risk for things not going the way with our treatment that we want them to go. And so we do this very comprehensive kind of 360-degree evaluation. We borrow principles of aging research to think about the concepts, and I'm going to give you some examples. This concept of frailty, which is a multidimensional measure of vulnerability to stressors. There's a lot of different concepts that go into understanding someone's own innate frailty sort of profile, I'll call it. And it includes the cancer itself, but it also includes things like your activity, your independence, your other medical problems that you are dealing with at the same time, your body composition, your nutrition, your mental health, your genetic predispositions. We know that frailty matters for patients with all cancers. In patients who have a higher burden of frailty, there's a less, patients have a decreased ability to tolerate the therapies that we might ask them to go through. There might be implications. We know that patients with higher burdens of frailty have shorter life expectancy. But importantly, there's also implications for functional status, burden of symptoms related to the disease, as well as side effects related to the therapies. And really importantly, this impacts things like quality of life, independence, and sense of dignity and well-being, which I think is really important. When we have a different sort of profile of risk and reserves, we know that patients will respond to the stresses of a cancer as well as the stresses of the therapies differently. And it can impact how patients bounce back and when they're going to bounce back from the treatments that we're talking about. So resilience is this kind of key modifying factor for risk. And here's the idea. Unfortunately, for better or worse, as we all age, our functional sort of abilities tend to go down a little bit every year. When we receive a diagnosis like cancer, a lot of times that slope of that line goes down pretty sharply. And that can be made, that sort of decline can be made even more extreme by the therapies, by the chemo, by the surgery. And then the question is, based on one's own internal sort of risk and resilience profile, the recovery can be variable. And that's why you see the different sort of red lines and the dotted lines. The concept I want to talk to you about today, and that Hannah and David are going to focus on, is how can we change that decline in that slope? How can we prepare patients so that maybe we don't see that fall off quite so substantially? And resilience, this concept of sort of being able to weather the storm, has actually been shown in research studies to date to really impact recovery after surgery. Patients who have higher resilience quotas or resilience levels, as measured using scientific surveys and sort of ways where we can quantify resilience, they tend to have less pain after surgery. That means they need less pain medication. They have better pain control. We see higher levels of quality of life, and we also see reduced anxiety. So there's some evidence. This is a pretty new field, I'll grant you that. But there's some pretty good evidence that is emerging that when patients have higher levels of resilience, the recovery process is a little bit easier. We have a resilience lab at the University of Washington, and when I was lucky enough to come here in 2018, I was able to make some friends over there. And I borrowed work that they were doing in the Foster School of Business, and we brought it into our bladder cancer program. And we started measuring resilience. We measured things like psychometric capital, efficacy, thriving, self-compassion in a group of patients who had bladder cancer were being seen in our multidisciplinary clinic. This is just a little bit of the data from this. We actually just finished writing this manuscript. It's going to be submitted for publication soon. But basically it shows that a lot of the resilience features track really closely with mental health, but they also track, interestingly, with some of the physical performance measures. And there's, I think, a lot of work to be done to start to understand how resilience manifests in our patients with bladder cancer. So I'd like to put forth to you that resilience is this multidimensional sort of assessment of reserves. It really, the other exciting thing about it is that it's modifiable. By tackling these different areas, we can increase resilience in patients with the goal of hopefully improving outcomes. So let's talk a little bit about how we can do that. The concept of prehab is something that I've become very enamored with over these last couple of years, but it's this process of trying to improve functional capability of a patient before they go through surgery, before they go through chemotherapy, before they go through treatment. And the whole goal here is to help patients get through the period where they're going to be less active, and then and also to reduce that decline and the downward slope of functional decline that we can see, and see if we can kind of mitigate that and help people kind of bounce back faster. We focus on modifiable risk factors with the goal of improving not only outcomes, but also candidacy for treatment. And there are some situations, especially, for example, in bladder cancer, where maybe not everyone is going to go through chemotherapy and radical cystectomy up front. Patients with non-muscle invasive bladder cancer may have many years, and hopefully they won't ever have to go through that, but they may have years before they might have to go through something like that. If we have this long kind of period where we know that there might be stresses in the future, we can use that time to be really active in preparation. The core domains are the physical, the nutritional, and the mental, and we're going to focus on the physical and the mental today. And so with that, I'm going to turn it over to my colleague Hannah, who's going to give you some really, really concrete solutions for improving resilience.
Can everyone hear me okay? No? Yeah. Okay, here we go. We're talking a lot about the word resilience, so I'm going to start by just talking a little bit about what resilience is and is not. Oh. Let's checking if this works. How's that? Better? A little bit better? Okay. We'll keep this as close to my mouth as possible. Okay. I'm going to start by just talking about what resilience is and is not. Resilience is a word that's used in the cancer survivorship literature and research, but I'll start with a physics definition of what resilience is. It's the ability of an elastic material, such as rubber, to absorb energy, such as from a blow, and release that energy as it springs back to its original shape. I call this section of the talk the trail map to resilience, and we're going to really hone in on this idea of going on a hike or being in the Pacific Northwest of a trail map. what resilience is not is that it's not something that we're born with, and it's not something innate to us. It's something that we build over time through our lived experiences, which is why we don't cope in the same way we did as when we were teenagers or when we were a little kid. We learn from those experiences and little challenges to build resilience. I think of resilience and prehab in a lot of P's. I separate them into this idea of preparation, prehab, pacing, and perspective. And the key of building resilience is that it has to be pragmatic and practical to patients, as well as personalized. Just like everyone's physical capabilities is a little bit unique, everyone's prior lived experiences, stressors, challenges are different. And our coping strategies, while overall we want them to be healthy coping strategies, are a little bit different from person to person. So if we imagine this individual who's ready for her hike, she's prepared by packing this backpack, but part of the preparation is she herself is prepared. She's done some cross-training, she knows what route she's gonna take, she knows how many miles she's capable of. So when we think about building tools or having tools for resilience, there are tools that we can accumulate or actively develop in preparation for surgery or cancer treatment. In terms of that preparation, we think of it in two different domains, the psychological as well as the physical. The psychological being those lived experiences, the ability to cope, and having that determination or perspective to thrive through cancer treatment. So our end goal is not necessarily just to finish cancer treatment or be in a stage of survivorship, but to be able to thrive so that patients can get back to the activities that are most important to them, as well as have a quality of life that is important to them. And we'll explore the physical in the next few slides. So the idea of exercise research in cancer survivorship is actually still new and emerging. It wasn't until 2022 that ASCO, which is the American Society for Clinical Oncology, developed exercise, diet, and weight guidelines, which is quite recent. And this is not, their recommendation, this is direct from the guideline, is quite practical. It's that oncology providers should recommend aerobic and resistance exercise during active treatment to mitigate side effects of cancer treatment. And while as practical as this sounds, this has taken years and dozens of exercise studies to prove. And we've learned that exercise is not only helpful for improving strength or increasing muscle mass, but the benefits really ripple into multiple domains related to quality of life, including fatigue, bone health, better sleep, improvements in mood, which we know are the side effects of a cancer diagnosis in itself, as well as cancer treatment. So in 2018, there was the American College of Sports Medicine held a global meeting of, I think, 40 plus experts in exercise and cancer. They looked at all the studies that were done to date in terms of exercise and cancer survivorship. And from this, they did what was called a meta-analysis, looking at what are all the benefits of exercise in different cohorts of patients that have had a cancer diagnosis. And they looked, most of these studies were either aerobic exercise or resistance exercise, and they found that these different colored circles or domains showed improvement. So this is one thing that patients can do that they have control over, or that they can be proactive about that can again ripple into many domains related to quality of life. We're still learning about what's the optimal dose, what's the optimal type of exercise that patients should be doing at different time points in their cancer journey, but overall learning that there are many benefits. A common phrase is that exercise is medicine. And I argue if exercise is medicine, first we have to know it's working, and we want to know what's the appropriate dose, frequency, or type of exercise that's going to make the biggest impact to each individual at different time points in their life. Overall, rather than a specific time or intensity, our goal is to decrease sedentary time. In recent studies, we've learned that even if we decrease sedentary time, so not necessarily engaging in 20 minutes of aerobic exercise or going on a walk, but if we can break up periods of sitting, that has shown benefits to overall mortality, not just related to cancer, but just in general health and aging. Looking at all these exercise studies, the American College of Sports Medicine, the American Cancer Society actually recommends the same dose of exercise for patients who are cancer survivors compared to anyone else who hasn't had cancer. And that recommended dose is 150 minutes of moderate intensity exercise per week, which can be swapped with 75 minutes of vigorous activity, as well as twice a week resistance training. But we know that every week doesn't look the same for someone undergoing cancer treatment, and 150 minutes can be like going from 0 to 60 for someone who's just had surgery or who is undergoing chemo. And that is where our exercise prescription or prehab has to be tailored to each person, as well as is allowed to evolve over time. And while this is a general goal, doing 150 minutes while you're having side effects from cancer treatment may actually cause harm. And while we don't necessarily want to just stick to this general recommendation, but we want to be able to create or develop an exercise prescription that's personalized and pragmatic for patients that's going to reap benefit. And I'm a huge proponent, just like Sarah, on the idea of prehab. So one example of an exercise prescription is we know if someone, let's say, a patient is going to have a cystectomy. For me, that personalized exercise prescription for that individual that I know is going to have abdominal surgery is, why don't we build up the abdominal muscles in anticipation for a surgery that's going to cut through them, and then it's going to need some time to heal. Similarly, when we think about prehab for a joint replacement, like someone who has knee arthritis who's getting a knee replacement, we actually ask them or tell them, try these exercises. We know you're going to have to do them after your knee replacement, so you know what it feels like before your knee has been cut into. So in that same realm, or with that idea, for prehab and cancer, we should be targeting muscle groups that we know are going to be either affected from cancer treatment or surgery to kind of build them up and anticipate for a little dip in function or a little bit of kind of loss of muscle mass and recovery, thinking with the mindset that that might help in the bounce back. So similar to other medications that we prescribe for patients, if exercise is medicine, I always argue or advocate that patients know what kind of exercise is going to be beneficial to them in terms of bang for the buck, knowing what frequency they should be exercising, as well as monitoring for side effects and knowing how this is going to work. So the first P is that preparation or prehab. And another key piece in cultivating resilience is pacing. So just because chemo's been completed, just because surgical precautions have been lifted, it doesn't mean a patient is expected to bounce back to the pre-cancer baseline. Just like an athlete who's had an injury, who is getting back in the game, it's really important when we see athletes to create something that we call a return to play protocol. So a pitcher who's had shoulder surgery doesn't start throwing 100-mile-per-hour fastballs once they're cleared from the surgeon. It's about getting that range of motion back, making sure things are pain-free, and slowly ramping up their cross-training. And in that same way, I think I advocate for for patients to incorporate these pacing strategies when getting back to their day-to-day, getting back to exercise. Again, with resilience not being something intrinsic to us or kind of something that we're born with, pacing is something that is a pre-planned strategy. So it can take some thought into planning your day to conserve energy. If we think of energy as during cancer or after cancer treatment as gas in a gas tank, we know that the metabolism has been affected by the treatment or side effects of treatment, so that's kind of taken some gas out of the gas tank. And with a limited reserve, I ask patients, what do you want to use the gas in your gas tank for? There are some necessities in the day-to-day, but we know that fatigue can be exacerbated when patients overexert. So we want to make sure that patients are, having a strategy to conserve energy for activities that you value, whether they're emotional, cognitive, or physical. It's important for patients, kind of cancer survivors, to sometimes cut down on their level of activity to find a sustainable baseline. And I'll show this in this next slide. Rather than overexerting and kind of seesawing between overexertion and needing multiple days of rest, I'd rather patients cut down on their baseline, find a routine that's manageable, finding an exercise routine that you can do on a good day and a crummy day, and then slowly building up from there. What can sometimes happen is that, and it can be incredibly frustrating to not necessarily have the same physical stamina that you used to, but patients will take a 60-minute Peloton class because they know they can do it, but then they're wiped out for the next 3 days. So it's not necessarily that helpful to have done that 60-minute Peloton class in terms of growing muscle or building progress. And in the exercise research, and this is not necessarily specific to bladder cancer, but we found that finding a sustainable routine when it comes to physical activity has much more benefit than infrequent bursts of activity. So doing that 1 hour Peloton class once every 2 weeks may not be as beneficial as doing 5 to 10 minutes of activity 5 times a week. A general rule, and again, this is taken from the sports medicine kind of literature, is 10% a week increases. So if you're able to walk half a mile, you shouldn't necessarily run the full mile the next day. So the idea is increasing 10% a week when it comes to distance or time related to physical activity or exercise. A helpful rule for pacing is something called the 75% rule. So if you think you can do something, when you're trying to find that new baseline, do 75% of that and see if you're able to tolerate it. And then just build 10% increases from there. For example, if you're gonna vacuum your whole house, and this is a practical, I think about this, just vacuum 75% of your house and see how you feel. If you still feel great, you can finish vacuuming the whole house, but it's nice to have that break in between to get a sense of what your body's telling you and what you're able to tolerate. In the exercise literature, there's known strategies that can be helpful for restarting that exercise routine. Helpful things can be enhancing enjoyment of the activity, whether it's listening to an audiobook when you're exercising or walking, talking to someone that you enjoy talking to, listening to music, as well as using an activity tracker. It can be as basic as having an exercise diary or activity diary, or using a digital health app on your phone or something like a Fitbit or smartphone. Social support is key, and I'll talk about that in the next few slides. I love the idea of exercise snacks because short bursts of activity of the day are just a lot more sustainable and pragmatic than doing 30 minutes, 40 minutes, or even 60 minutes of activity if you're having side effects, fatigue, or other kind of sequelae of treatment. The idea, my favorite exercise snack is a sit-to-stand, and as a rehab doc, we have to break up some sedentary activity. So I'm going to have everyone kind of sit up in their best posture in their chair if you're willing and able. And then a perfect sit-to-stand, and I'm going to have maybe Sarah and David demonstrate, but I'm going to have you sit close, and they're at a disadvantage because these chairs are very short or very low. So yeah, an ideal sit-to-stand is the movement of getting out of the chair without your knees kind of caving in inward. You want to keep your knees and your feet hip-width apart. You're just really activating the muscles behind the thighs and on your behind, and just standing. Oh, beautiful. Oh, love that. Okay. And then a sit-to-stand is exactly what it sounds like. So it's going from sitting to standing, and then standing to sitting, without, and hopefully we're hearing no plops into the chair. So it's a nice, slow, and controlled movement. So I think a great exercise snack is just adding 5 to 10 sit-to-stands with breakfast, lunch, and dinner. And that if you do 5 with breakfast, lunch, and dinner, that's 15 more sit-to-stands than you would have done otherwise. And what's great about a sit to stand, and we hear a lot of people say, walking is the best exercise, but while walking is great and it's a great aerobic activity, walking doesn't necessarily help individuals navigate stairs or get in and out of a car. So a sit to stand is a great low impact strengthening movement to activate big muscle groups that can translate into better walking, but also translate into more functional activities like getting off a low surface or navigating stairs. And perspective is the last P. I love this quote from Maya Angelou. She says, I can be changed by what happens to me, but I refuse to be reduced by it. And we were talking about resilience, and again, we talk about bouncing back to a baseline, but it's really more than that. It's about being able to thrive through and after a cancer diagnosis of, yes, we want patients to be as physically active as they were before, but we know that there are physiologic changes to the body that happen. So it's not just about returning to a pre-cancer baseline, but being able to thrive through treatment and a diagnosis to become better. And that can look like taking on new hobbies or taking on new physical feats or activities. And it can be psychologic of being able to take on new challenges, whether they're emotional or social. And I think that can be a beautiful thing in cancer survivorship. And a last P we'll throw in there. In terms of those lived experiences that grow our mental muscle and our psychological resilience, community is a huge part of that, which is why Beacon is so amazing, because we can thrive way better together. And in terms of an idea of a hike, these groups look like they're having a great time, and sometimes it can be very obvious. A group hiking together, that's a shared community. But there's, I would say one example is for anyone who likes to hike, say you're by yourself and you just don't see the summit. You're on a bunch of switchbacks and you should be getting close to the top, but then you see someone coming down from the summit and they're like, you're 5 minutes away, How much hope does that give you? And while they're not part of your healthcare team, it's not your friend, that's part of a community, of a shared experience, and I think that's something that Beacon can help provide. And having that really does build psychological resilience that adds to your mental muscle or mental reserve of being able to cope and move forward and develop connection. And I think next I'm going to pass it on to David to talk more about that cognitive aspect.
Sorry, check 1, 2. Good, thank you. Hi everyone, so thanks again. I'm here to talk a little bit about cognition and our thinking skills, and it's what I hope to communicate too is a lot of the strategies that Hannah and Sarah have talked about are also very relevant to our brain health long term as well as day to day. And so just to start, I just want to talk about the overall prevalence of cancer survivorship as a whole, as well as what that means as it relates to brain functioning for all of us as we get older. So in general, if you look across cancer populations, you can see around a quarter or so of patients have long-standing changes or some changes after cancer and cancer treatment. And if you pair that with the graph on the right here, where overall there's this expected increase in the number of cancer survivors living in our world, you can imagine that this is going to become a growing and increasing challenge that we all are maybe going to face, including cancer survivors and people who care for cancer survivors. Just to start, we're going to spend a bit of time on cancer treatment, but there's a lot of literature in various cancer populations to demonstrate that there are changes in thinking skills that can occur before any surgery, before any chemotherapy, and before any radiation or any other treatments. So this is a series of studies. I know it's a graph and some people's eyes glaze over, especially after lunch, but just to walk you through this a little bit, each of these bars represents a different study of a different kind of cancer. And I've highlighted in orange bladder cancer. This is one study that was done. And for each of these groups, like for example, breast cancer, leukemia, colorectal cancer, you can see that the higher the bar represents a higher rate of cognitive difficulties in that cancer group. And again, this is well before any chemotherapy, any surgery, any radiation. And the takeaway from this slide is that we can see cognitive changes before any treatment for cancer. And so there are some known effects of cancer itself. So today I'll talk mostly about treatment, but regardless of your treatment history, some of the strategies I talk about may be very relevant to you, regardless of what your treatment history has been. So that being said, I will spend a bit of time talking about treatment effects, because that's where a lot of the literature and a lot of what we talk about with patients involves. So just in general, when I'm thinking about bladder cancer in particular, there's a couple studies out there that look at cystectomy in particular, and there was no significant findings of acute changes in cognition after cystectomy. What this doesn't include, though, is general anesthesia effects potentially, including multiple general anesthesia events, throughout life or over time. And so there are some known cognitive changes there that can, and for various individuals, can affect cognition. There's also systemic chemotherapy and radiation. A little caveat from all the information I'll present today is a lot of the literature is actually primarily in breast cancer. And that's a limitation of the research, but I will say, as someone who works with patients from various cancer backgrounds, all of the findings are quite relevant to all cancer types. It just happens to be primarily in breast cancer where a lot of the data is from, and we hope to change that over time. Some of the newer therapies like immunotherapy and immune checkpoint inhibitors, those have growing evidence, but there's not as much known right now as far as cognitive effects. And then what I'll spend probably most of my time actually as a clinical psychologist, both today and with my patients that I work with, is this last bullet point here of other factors: mood, fatigue, pain, and the lifestyle changes that can happen as a result of cancer and cancer treatment. Those have known effects on our cognition as well, so we'll talk about that. In the literature and just in our clinical sphere of working with patients with cancer, we've seen this really big explosion of interest in this term chemo brain, and you've probably heard it. This is just a graph showing just scientific articles published over recent years, and you can see this big spike in interest from researchers in this term chemo brain, and so much so that there's medical websites out there that just have whole pages describing what chemo brain is. I like to listen to patients, and there's a really nice article that was published in Breast Cancer Survivors, and in particular underserved African American breast cancer survivors. And they asked, this is a qualitative study, meaning they ask, how would you define as a patient what chemo brain is? And they took some themes, and the big picture ones are things like fogginess, forgetfulness, going blank. Why am I not doing this the way and as quickly as I used to before treatment or cancer? I backtrack, I forget where I put things. And then the other day I asked my son, where's my telephone? And I was talking on it. And these are, you can kind of imagine, these are kind of the themes that we see, and I hear these very frequently from the patients I work with, of what chemotherapy does to our brain and our functioning. One common thing, and this is maybe a little bit for me as a neuropsychologist, is sort of a head scratcher, is we oftentimes ask patients, are you experiencing changes in your thinking skills? And very frequently, and that's what the graph on the left here is around half of patients say, yes, across cancer populations, I'm having some changes. And they come see someone like myself as a neuropsychologist, and we give some memory tests and some attention tests. And it's actually a very common finding where our tests don't really find what patients are telling us. And when I give this talk to my colleagues in neuropsychology, we blame our tests, or we say that patients are maybe don't have as good of insight into what we're seeing. And I actually like to really spend some time with this because I think there's some relevant data to support what patients are actually experiencing. And it starts with the brain. This is a meta-analysis, so a number of studies that were compiled into one, looking at imaging of the brain. And all the colors mean different things as far as changes in structure or function in the brain. And the big takeaway from this is that if you look at all the studies of neuroimaging, of MRIs of the brain after chemotherapy, there are changes in the brain, and we can see that in the brain. What this means for patients is, I think, demonstrated here in a study of twins. And I'll sort of walk you through this, but this is a case study, so it was a twin A who had a history of cancer and chemotherapy, and twin B, who had no history of cancer, no treatment for cancer. And they asked twin A, do you have cognitive concerns and changes? And they say, yes, I do. They asked twin B, do you have cognitive changes? They say no, as we'd expect. They haven't had any chemotherapy or cancer treatment. And we do testing for both of them. We give them some memory tests, some attention tests, and by and large, similar to what I presented with those pie graphs, is people, these two cases in this study, perform the same on their measures. But what changed is when we put them in a scanner, or when the researchers put them in a scanner, they found that despite that similar performance on the test, twin A, who had cancer and treatment history, their brain was working a lot harder to do the same activity. We'll talk about fatigue, and Hannah mentioned physical fatigue, and to me, this is how I describe a patient's cognitive fatigue. I'm doing the same task, but it's a lot harder. I'm working harder to get there. This is evidence for what patients tell me all the time. When we look at the big picture, overall across cancer groups, there tends to be fairly mild weaknesses in cognition when we do some testing and find them. They do, however, affect everyday functioning, and that's what I'm most interested in, is helping patients minimize the effects of cognitive changes. As far as the course, it can vary from individual, but most people tend to have resolving of cognitive symptoms after about a year. But I'm here to tell you there are many patients, or a number of patients, I should say, that do have these persisting cognitive changes beyond the 1 year and even into some decades after, which we can find in our studies. I often get a question about radiation, and it's a little bit less, there's less, the evidence for radiation affecting cognition is not quite as strong. It tends to not show up on our testing, but in the year or a year and a half after radiation, there can be symptoms that patients present with as far as cognitive changes. So that it does have some evidence for impacting people's perception of their cognitive performances in daily life. What are the big areas that are affected after treatment for cancer? The big ones tend to be learning and memory. So for example, remembering items on a shopping list. And I put in some really important language that I like to specify is learning, so acquiring new information, or retrieving, so pulling in and getting that item off the shopping list when you're at the store in front of the shelf trying to remember what it is. That's a very common change after treatment for cancer in general. Speed of mental processing, or how quickly our mind is working. So if someone is speaking very quickly, trying to keep up with that conversation might be an example of this. Maintaining attention over time. And then this last kind of square here of executive functions, which means a lot of things, but it's things like switching between tasks. Like if we're trying to cook and also we get a phone call from our doctor's office and trying to attend to that at the same time, or switch our attention. Problem solving, and organization and planning. So these are sort of the four main areas that we tend to see changes in after cancer treatment. So a lot of times, so I mentioned changes after cancer and then also treatment, but there's really more to it than that. And this is, I think, what resonates with a lot of patients that I speak with, is that cognitive functioning, if that's in the middle of this diagram, there's more to it than just this little purple bubble of chemotherapy and cancer. There's stress, there's anxiety, there's fatigue, depression, pain. There can be hormonal changes, medication effects, and these are just to name a few. And oftentimes this involves working with the medical team to address these. And at the same time, there's a lot of strategies that I'll go over that I think are kind of the greatest hits of strategies to manage some of these common factors that can affect cancer survivors. So we're going to really focus on that, is what are sort of the, again, I frame this as maybe the greatest hits of cognitive strategies, and some may be more helpful for others, but I like to go over them sort of from the beginning, which is, in general, where I start with patients is to look at your own cognitive lapses in day-to-day life. What have you noticed? Maybe journal them, maybe put a check mark every time you notice it, and also monitor other things that are potentially contributing to our cognitive changes. So for example, mood, fatigue, pain, medication side effects. Are those contributing in some ways to the cognitive lapses you have or are having? And then, of course, we'll weave in some strategies that I have that are good, but also talking with your healthcare provider and your medical team about those factors if you think they may be playing a role. I always like to just start too with cognitive symptoms are sometimes a result of being a human being, and it doesn't necessarily mean that you are having changes due to cancer or cancer treatment. So this is just a survey that was done for adults and older adults without cancer history or cancer treatment, and saying, what are some things you've noticed? And you can see the percentages there, anywhere from half to a significant proportion of people saying, I forget people's names, forgetting where my car was parked. You may see me in the parking lot after trying to find my car, right? This is a common thing that happens to all of us. And because you have a lapse, it doesn't mean necessarily that it's due to cancer or cancer treatment. And there, again, may be other factors. And so asking yourself, what contributed to this instance that could be addressable or modifiable? And that's a good starting place. There's this big question for us in neuropsychology and in psychology of, what do we do to help patients get back on track, or to rehab or to prehab? And a lot of patients also ask, are there things I can be doing, brain games, exercises? And so we've done quite a bit of research in this area. And the big question is, do we try to restore cognitive functioning? Do we get it back to where it was by training our brain or doing exercises on the computer or on paper? Or do we try to give it support? Do we try to give it compensatory strategies, reminders, cueing? And if you take that literature as a whole, the big picture is that there's a lot of evidence for compensation or strategies for our brain as being the best thing we can do to keep our brain functioning in daily life. And so a lot of the strategies I'm going to go over are focused in that area. So to weave this back to Hannah and Sarah's discussion about prehabilitation, I really want to emphasize that there's no wrong time to implement these strategies. These can be prior to cognitive changes or after you've already noticed them. And they also don't have to be for patients alone. They can be, I think everybody could benefit from these, including care partners, family, your providers, everyone could use these. So I think they're very relevant to everybody. So a couple main kind of greatest hits that I like to start with is an external notebook. And that could be a planner, it could be a to-do list or a notepad. It really is whatever is most helpful for you. But I do like to emphasize that in terms of memory and cognitive strategies, more is not always more. Sometimes less is more, and sometimes it takes simplifying our strategies. If you have multiple notebooks, your brain is now tracking multiple things, and it may actually increase your cognitive load, and we want to keep it as simple as possible. Another strategy I often will implement with patients is setting a time aside in the day to review your planner. Sometimes we just sort of keep working with it and throw things down as we think of them, but sometimes setting a time in the morning or in the afternoon to really think about what is it that I'm doing later today or tomorrow, setting that time aside almost like an investment of time to make sure you're really thinking ahead and what you can do. That time goes a long way. Same for weekly, kind of setting a time aside Sunday mornings or Monday morning or Friday afternoon, some time to review your planner just to reset and have an understanding of what's maybe in front of you. Other external compensatory strategies, I'm really big on setting alarms, and these are to decrease our cognitive load. We're not always thinking about it, but if we're trying to remember when the next task is or what's coming up, that's more brain energy we're not spending on the things that are important to us in front of us. And so using alarms, cues, whether that's on your phone or in your calendar, if you have an electronic one, those are really, really great strategies to support your brain's functioning. I always like to present this strategy of a central place to keep all your items. And some patients will say, well, that's not a problem. I remember where things are. That's fine, but the challenge is that your brain is tracking all of those things at the same time. We want to minimize the noise and the information our brain is tracking. Even if we're remembering where things are, we want to still minimize our brain having to track that. So a central place, table next to the door, kitchen table, something that is a place where everything goes. And then things like pill boxes for organizing medications. Again, even if you're good at doing that, it still minimizes that load that your brain is having to monitor and track out of pill bottles. Did I take it? Did I not? Giving our brain those structures. This slide may not, sorry, I'll have to go back. There's supposed to be a slide, and I'm so sorry, but I'll demonstrate it with my hands. There's this analogy that I like to use with patients, which is our brain is like a cup. So our cup can only fit so much water into it before it overflows. Water would be information, things that you're provider is telling you or your family member is telling you. So that's the water that's going into your cup, and your cup is your brain. And there's these ice cubes that can take space up in our cup. What are ice cubes in this case? They're distractors like worrying, like fatigue, like pain, or external distractors, other things happening. And so the analogy I like to give is that there's space taken up in our brain by those distractors from a physical brain energy perspective. I use the term here, brain bucks. Ice cubes are taking up our brain bucks if the ice cubes are pain and fatigue and worrying, those sorts of things. And so as much as we can minimize those factors, it frees up space in our cup, in our brain, to fit more water in. So some of the strategies earlier about maintaining fatigue or managing fatigue, they go a long way for our brain and our brain's energy. So we're going to hear a little bit, I think the next talk is actually on mental health and behavioral health and well-being. And I want to highlight that that's one of the ice cubes, is our emotional status in any given moment. If our brain is processing sadness, down mood, anxiety, stress, that's the same brain that is also processing an important conversation with a loved one. And so if we can manage stress, manage mood, it helps free up space in our brain to attend to the activities that are important to us. Some of the strategies that have support for in-the-moment stress management, or some of them are listed here. Diaphragmatic breathing or paced breathing, various forms of getting that parasympathetic nervous system engaged so that we're not in that fight or flight response, is a good starting place for a lot of the work that I do. Things like meditation, mindfulness, yoga, or chair yoga all have support for maintaining our cognitive functioning and our mood as well. And then, of course, if that's not enough, as far as weaving your own strategies, really thinking about whether something like psychotherapy or talking about mood with your doctor is whether there's additional treatments is always a recommendation. And I like to really talk about fatigue from this model of, a lot of times we talk about fatigue from a physical standpoint because it's physical energy, and there's also emotional fatigue and cognitive fatigue that can occur. And I think this resonates with a lot of us of, sure, I feel more tired at the end of the day and I'm maybe emotionally exhausted or cognitively exhausted. The flip side of this, and the beautiful thing about this model, is that it doesn't take addressing all of those factors at once to help improve our thinking skills, for example. And in fact, what I mean to say is that when it comes to managing cognitive fatigue, a lot of the strategies that Hannah went over about pacing, about regular physical activity that's consistent and not overdoing it, even if you feel energetic, is in sort of taking regular breaks from a physical functioning standpoint, have evidence for also supporting our cognitive health. And so when I work with patients who have cognitive fatigue and their brain is working harder, this is actually the same starting place for me as what Hannah talked about, is trying to manage your physical fatigue all fatigue through physical activity. And so all those things that we talked about, regular physical activity, pacing, energy conservation, they do numbers for our brain as well and its functioning. I am really big on sleep. It's easier said than done because sleep is so different for all of us. But I like to just start with general sleep hygiene practices because so much happens for our brain during sleep. And a big part that I like to talk about is to nap or not to nap. I like to describe sleep as a hunger. And if you eat a snack right before a big meal, you're less hungry for that big meal. Likewise, if you nap before going to bed, sometimes it can impact your sleep quality. Now, that's different for everybody, and some people need that nap. I also just like to talk about what that may or may not do to your sleep quality each night. And so napping is always something I'll talk about with patients. Keeping a consistent schedule is a big part of managing sleep and sleep hygiene. Sort of the general ones of minimizing caffeine use in that afternoon to evening time, avoiding alcohol before bedtime or at all, and then also turning off electronics that 30 minutes to an hour before bed. The biggest one that I probably spend most of my time talking about from a sleep hygiene perspective is actually this last bullet point, is trying to train our brain to associate bed with sleeping and not with staying up or worrying or thinking or tossing and turning. And so one of the best things we can do is sort of teach our brain that when I'm in bed, I am sleeping, and if I'm not sleeping, I get out of bed. So for example, one of the concrete strategies I'll give is give yourself around 20 minutes to fall asleep, maybe a half hour, or how long it takes typically for you to fall asleep. And if you haven't fallen asleep, is to get out of bed, do something low light, boring, until you start to feel sleepy, and then go back to bed. We want to train our brain that when we're in bed, we're sleeping, and when we're not sleeping, it doesn't get to toss, turn, think, all those things that it likes to do. That's a time-intensive strategy. It's a marathon, not a sprint, so it takes some time, but it is a really helpful strategy for helping us associate our bed with sleeping. And I'll end on this note. A lot of times I'll talk with patients about we're all in this room getting older, and what can we do to keep our brains healthy? And when we look, and a lot of this studies are out of sort of the dementia literature, but they're very relevant to cancer survivors, and they're all the same recommendations that we often hear from our doctors, which regular physical activity. We talked about it from a fatigue management standpoint. It's also keeping your brain healthy in the long term. And it's been shown to help memory and executive functions. Diet, so Mediterranean diet, fruits, veggies, whole grains, fish. These have known effects for minimizing the risk for cognitive decline long term. And so that's borne out in the literature and in some of our studies. And then the last thing is really thinking about risk factors for cognitive difficulties. The big ones that stand out are untreated sleep apnea, high blood pressure, high cholesterol, and diabetes. Those risks are minimized by treating them as far as cognitive changes over time, and so working with your medical team to really treat those factors. And then the last thing, if you summarize this slide, is that brain health is really just heart health, and so it's quite easy just to think about if you know it's good for your brain, if you know if it's good for your heart, it's also good for your brain. And so just to highlight that you are doing the wonders for your brain long term by also doing what's good for your heart. And then I think one of the big questions, and I'll end here, is where do I start? And I think, I outlined a couple examples here, but something like just starting a to-do list. In fact, there's a nice notebook on all your tables if you wanted to start that as a running to-do list and to check it each day. Set an alarm to review it each morning or afternoon. Another one might be just taking a regular break, setting an alarm to cue your brain to take a break, maybe do some diaphragmatic breathing or stress management each day to help give your brain that break and to pace our cognitive energy over time. I mentioned diaphragmatic breathing, maybe something like that once a day for 5 minutes. And then lastly is really thinking about physical activity from a fatigue management, things like going for a walk, but also things like, sit to stands or chair yoga, whatever it is that you're able to do as a way to help maintain your brain health, both day to day, but also in the long term. And with that, we're going to talk about or I won't, but Sarah's going to talk about some exciting upcoming work.
Thank you. That was great. So I actually just learned a whole lot. That was the first time I've heard David give that talk. And I think that there's increasingly, I actually have patients when they come in who ask me really good questions about how's this disease going to affect my ability to think, my ability to do my work, my ability to read, to have conversations. And I also hear when patients may not describe my cognitive processing isn't quite working the same way, but they may say that they may bring up the fact that they're really struggling with some of the aspects of how bladder cancer itself, but also how the treatment is impacting their ability to kind of function in life. And I'm really glad that you've joined our team, because I think that we can learn a lot from you of sort of strategies, strategies that I can use, but strategies we can all use to really optimize our cognitive functioning and to maintain our independence. And I think that the fatigue pieces are a really key aspect of that. In the next couple of minutes, I just want to take a few minutes and share with you some really exciting work that we're kind of embarking upon at the Fred Hutch. And then I was hoping we could turn this into a bit of a discussion. And so we'll have a good amount of time for questions. And we all want to hear from you and talk a little bit about how you think about resilience, how your thoughts on that have impacted the way that you've approached your treatment and survivorship. But Hannah and I, so Hannah, when did you join the Hutch? It was 2-3 years ago now? Yeah, so I had been working on the risk and risk stratification piece of things, but here's the fun part about research, right, is you start by focusing on a problem, but then the second you've kind of defined the problem, all you can think about is what's the solution. And so I was thinking about risk, and I was thinking about how to sort of really understand my patients' risk profiles. And then all I could think about was, oh my gosh, how do we start moving the needle on these risk profiles? And that's where the whole thankfully, that was at a time when prehab was starting to really gain some traction in our literature. And in 2022, Hannah and I co-chaired the think tank breakout, where we introduced the concept of prehab here at the think tank in Beacon. And we finished our discussion, and Hannah and I were just blown away because there was just this resounding cry from the room: why isn't anybody doing this? Why? We had patients, as you know, this is a group that I think is fairly representative of Beacon's reach. So we had a group from across the country, and patients were saying, nobody ever talked to me about this. Why don't I have prehab at my institution? And so we sat down and we thought about that long and hard. A couple of years ago, one of my medical students and I decided to take a look at the prehab literature. And we just published this now 2 years ago. But one of the things we looked at the prehab studies that have been done in urology. And truthfully, when we started looking at this, there actually wasn't that much. And especially most of the work had been done in prostate and then a little bit in bladder cancer. But we noted that there was definitely an increasing enthusiasm for the work, and lots of studies were being done, but most of the studies weren't hitting their marks. They were not successful in achieving the outcomes that the prehab was being designed to achieve. And once we kind of looked at all and synthesized all the evidence, we looked at it and we were like, well, why isn't it working? And there were kind of four main issues. The first is the availability piece, just what our patients, our participants in our think tank breakout session were saying. They're like, this just doesn't exist at most hospitals. That's a problem. That's especially a problem if you work in a place like we do, where we take care of patients from 5 different states, and sometimes patients fly from further to see us. If you're coming across from Yakima to have your cystectomy, we certainly aren't going to ask you to come from Yakima once a week for an exercise session, or 3 times a week for an exercise session. That's just not practical. The other issue is effect. A lot of times, many of the prehab interventions that were being tested were, do you all know what high intensity interval training is, or HIIT? Okay, so we're talking about flipping tires and moving big ropes and jumping off things. I'm sorry, as much fun as that is, that's not really something that we can ask patients who are getting ready for abdominal surgery, who are getting ready or going through chemotherapy, who are having medicines put in their bladder. We can't realistically, safely ask patients to do that. And some patients maybe, but it's not certainly applicable to everyone. So having that be the intervention is really not a great strategy. We have to think, obviously, about pragmatism and all of the different effects that impact patients' ability to get to an activity, to participate in an activity. We have to think about safety. A lot of times, obviously, our patients who are going to engage in these prehab programs are going through some pretty intensive treatment. And so we've got to think about, we have to be responsive to changes in their physical status, symptoms they may be having, toxicities they may be experiencing. We've got to think about what Hannah was talking about. We've got to be nimble. We have to be able to modify these programs. It can't be one size fits all. And we got to think about cost. Bladder cancer is the most expensive cancer that we all treat. It is so expensive because it is a cancer that affects all aspects of life. The therapies and the diagnostic procedures, unfortunately, are quite intensive for patients to go through. Many of them are very invasive. And as we talked about, it's lifelong surveillance, oftentimes, or extremely protracted surveillance. So we can't ask patients to then also put a gym membership and the gas money to get to the gym and coming in to see us at the cancer center so that we can watch you ride a bike. That's not going to work. So we took all of this to heart. And we recognize the fact that really what's been tested is kind of the Lamborghini. I'm going to suggest that we all need a Subaru. That's what I drive. And we need something that's practical and scalable, and that we can get out and we can soup up or soup down. but we need something that's going to work for everybody. So this is what we kind of put our, we really went to task on this, and we thought long and hard about how we could do this. And so I want to introduce to you the Get Moving trial. This is a trial we've been recruiting for now about 3 months, just under 3 months. It's open at the Hutch. This is a randomized controlled exercise trial. It is a pragmatic home-based exercise intervention. And we really focus on delivering these personalized exercise prescriptions. So Hannah makes our prescriptions for all of our patients on this trial. But the idea is that after a very careful evaluation of a patient who's about to go through neoadjuvant chemotherapy and is anticipating a radical cystectomy, these patients are randomized to either receive the exercise intervention or go on standard of care, which is recommendations that that Hannah talked about, those recommendations from the American Association of Sports Medicine: 150 minutes of moderate activity a week, 75 minutes of intense activity, some resistance training. We deliver the exercise prescription through an app that has been built out by our collaborator, Dr. Cindy Lin's team. Cindy and I actually went to medical school, which has been fun to kind of reconnect with her. And they have this really amazing app that runs on a smartphone that can not only provide you with our prescription that Hannah designs, but then also tracks a patient's adherence to that using some very fancy technology that all of our phones carry in terms of things like the Doppler ability, so using sound waves to track activity, and also everyone wears a Fitbit. So this is the trial schema. It's a randomized controlled trial where patients are randomized to either an exercise arm or a standard of care arm. The exercises are pragmatic. They're things that can be done at home without any additional equipment. It takes about 20 minutes a day, time, I'd say they're healthy exercise snacks, a little bit more than 5 minutes, but it's about 20 to 30 minutes of exercise. The idea is for it to be done 4 times a week. And we're asking patients to do those exercises as they're going through systemic therapy before surgery, and then also after surgery, but it's a pragmatic trial, so the intensity changes as patients get stronger, and then after surgery we drop it down, and then we sort of appropriately ramp it back up, commensurate with the recovery. And we're tracking an impact on things like physical activity and strength. We use something called a short physical performance battery, which measures balance and gait speed and lower extremity strength. But we're also really looking at the other measures that we think are important, things like quality of life. So with that, we're going to conclude and open the floor for discussion. I hope what you've gathered from what we've talked about today is that prehabilitation can be a tool to cultivate resilience. It's not a one-size-fits-all tool, and it's a tool that's multidimensional. It can really be crafted to fit the personalized profile of a patient with respect to their risk profile, but also their resources, their strengths. And we can really work to cultivate and build those strengths. We definitely think that there's emerging literature that would suggest that this kind of work can improve outcomes. And the goal here is to optimize physical performance, physical function, independence, quality of life as one goes throughout one's day, to also improve things like cognitive function and executive functioning. And then significantly, our goal here is to try to manage some of the negative, big impacts of cancer: anxiety, distress, fatigue. We'll keep in mind the P's. I really love that paradigm that Hannah introduced. And with that, we'd love to take any questions and hear from all of you about what your thoughts are on resilience and cancer.
So the easiest way so we can record this, because we'll let this live on our website, is if you would come up to a microphone to ask a question. I know it's a little tight in here, but if you have a question, if you could come up to a microphone. I'm going to ask a question. How many of you would be interested in signing up for their trial? Oh, you've got recruitment here. Do you have?
All right.
Who should they call?
We are actively recruiting. So
well, you've got a few people right here. But are there questions on any of these topics in terms of, getting ready for your procedures and rebounding and just getting back into shape and the mental health aspect of it? Any questions? Yes, come on, Brandon, come on up to the microphone if you don't mind, just because we're recording this.
Can you hear me now? Okay,
We can
wonderful.
hear
I just wanted to start out by saying thank you very much for the presentation and highlighting that going through cancer treatment, it's a very holistic experience, and it's more than just the cancer. It's your mental capacity, physical capacity, and all of that is integrated into one. So my question focused on the cognitive function and how would a caregiver go about identifying cognitive decline, and then what tools would you recommend them in identifying that? Because a lot of times cognitive decline is very insidious, where you as a provider, you only have a very short glimpse into that interaction, and you may not see what's going on in the home. So what would your advice be to the caregiver, and then how to go about getting the proper testing, and then the next steps for someone they feel who is experiencing cognitive dysfunction or cognitive decline during treatment?
Good question.
Great. I'm happy to field that question. So first of all, great question, and thank you so much. The one thing I like to do is just to present caregivers and family and care partners as their advocates. And so just the first part is oftentimes family, I'll see patients and I'll invite family to come with the patient so that I can have another piece of data, because oftentimes cognition can impact our own ability to understand changes in our own thinking. And so someone like a family member oftentimes has one of the better perspectives, and so giving them the power and the autonomy to communicate or to be able to reach out and try to find the next steps to assess for thinking skills. As far as what to look for, I always like to just start with really trying to find, one is where was somebody maybe prior and sort of at their optimal functioning as far as cognition. That's oftentimes what I'll emphasize in thinking, what are the changes that someone's noticed, and what are the specific instances that those changes occur. As far as next steps, so I really like to take a team approach. I'm in the Department of Rehabilitation Medicine, and so I am a referral service in neuropsychology, so I work closely with physicians who refer patients to me. And so I really recommend starting with your either oncologist or even another medical provider, making sure that you're connected with the right providers to assess for thinking skills changes, whether that involves someone like myself, like a neuropsychologist, to really assess for memory changes using our testing, whether it's in neurology and MRI. So making sure you start with one central provider to make sure that patients are connected with the right next steps. As far as, and I don't know if that answered your full question. I may have missed a few. You had some really great ones in there. I'm sorry if I missed one.
No, you answered them for the most part, but I know a lot of interactions with patients and patient family members, there's always this, well, I don't know what to ask, or I don't know what to look for. So just giving that foundational, this is where you should go, and those first steps are pivotal when it comes to taking care of our cancer patients or bladder cancer patients. So thank you very much.
Thank you.
So I do have a question. For those who are in this geographic area, they know that they have this phenomenal resource at the Fred Hutch. But what about for people elsewhere? How would somebody who is flown in from Illinois or something, maybe they have more large institutions there, but think about a more rural community. How would you find help for some of these issues or preparation for some of these procedures? How do you do that within a community-based practice? That's a good question.
That's a good question.
Let's see. Can you hear me? I would say that's the basis behind the need for a pragmatic prehab structure that's generalizable or that can be utilized in rural settings, in urban settings, just to decrease burden of travel and costs to patients. But I think there are communities that where we have to think about telehealth as an option for something like physical therapy, which is highly utilized in some communities to decrease the challenge of a patient traveling to a hospital or a physical therapy site, of making it as pragmatic as possible. So I think there are some institutions that utilize telehealth physical therapy or even telehealth rehab psychology services to decrease the hours of travel potentially involved. And sometimes our goal is to have a personalized exercise program or a personalized prehab program, but there are some institutions sticking to a more generalizable prehab program of, like, let's say, general core exercises to do before a cystectomy. So I think we're aiming for it to be as personalized and pragmatic as possible, but I think telehealth and doing some exercise or some psychology is better than none.
I would just add as well, I think a huge part of this is awareness. It's awareness that we can move the needle on a lot of these domains. We can strengthen patients. And sometimes I will also say a lot of patients may not know the resources that exist at their community hospital. Sometimes it's a question of asking. Because I'll say, even we actually work at the same institution, although I work at Montlake at sort of one of the surgical hospitals, the Bingham hospitals, and these guys are over at the Hutch, and I don't actually cross paths with them on a day-to-day basis. I'm not aware of maybe of all of the resources we have within our own institution. So I think it's really important for patients and providers, patients and caregivers, to sort of, I want to just thank the last question asker, because I think that, like, just having awareness that of sort of the holistic impact of cancer on a survivor's experience, and asking about being proactive, see what is available locally. But then the other thing is that there are resources like the BCAN website, like on the Fred Hutch website. If you're interested in nutrition, for example, I think there's going to be a talk tomorrow on some of the resources we have there that they're just all based on the web. There's an entire website of sort of recipes that are built for symptom management and optimizing nutrition. It's called the Cook for Your Life website. So I think there's a lot out there. Part of it is we have to know to look for it, and then the alternative is also going to great sort of information hubs like the BCAN website, like the Hutch website. And I think that we're getting better and better actually in this sort of digital age with sort of disseminating these kinds of programs. I think it's going to be easier with cell phone-based apps and things like that, and telehealth for sure. But I think a big part of it is being aware that we can do this.
You have a question?
No? Okay. This is great information, and a lot of it I've heard before because I have a background in clinical social work, so I was busy telling people how to improve their lives. And then one day I got this diagnosis. And anxiety is such a central feature, I'm sure, for all of us when we first hear about it. And it was pretty overwhelming for me because it just came out of the blue. And then to make matters worse, about a year and a half ago or a year ago, my oncologist said, "Oh yeah, you have an 8% chance of living to 5 years." So, that tells you what group I'm in. So, my attitude about that was, this is overwhelming, and my best strategy for it was ignore it completely as much as I could and just do things that I like to do, and I've done that pretty well. I mean, almost to the point where my brothers and people, "Oh yeah, I forgot you have cancer." And, I've done pretty well with it statistically, but still, when I come to this meeting, it kind of forces me to think about this much more directly, and again, just deal with the anxiety associated with it all. And I'm trying to figure out what a good specific strategy would be to manage that while acknowledging it, but not letting it just take me down, because my goal is to live life as normally as I can. So I don't know how to come up with that specific strategy. These are all a lot of good suggestions, but it doesn't quite get there for me.
I think you've hit the nail on the head, which is that none of this is going to be right for everyone. But managing that anxiety and living well from diagnosis through treatment and then into sort of post-treatment survivorship is really the name of the game. That's going to look different for everyone. One of the other sort of key areas of my research portfolio really focuses on helping patients as they age sort of deal with the combined double hit of aging and all that brings along. Multiple medical conditions, changes in functional capacity, things like that, and then a cancer diagnosis on top of it. And so I think at the end of the day, it sounds like you're doing actually what I hope everyone does, which is you thought about what matters most to you, and you're going after that. And so one of the conversations I have with a lot of my patients is I say, well, what does a successful outcome look like to you? What is if we look at ourselves in X amount of time, what is the thing you're going to say, if I'm not doing that, I will not have had a successful outcome? And then we do everything we can to make that happen. And maybe it's throwing the kitchen sink at the cancer and doing the most aggressive things we possibly can, and maybe it's not. And that's okay. Because at the end of the day, it doesn't really matter. There's no judgment. The judgment is, at the end of the day, what makes you the happiest. So managing your anxiety, one's anxiety going through all of this is a really key component, and focusing on quality of life and sort of what we call patient-centric outcomes, as opposed to the kinds of outcomes that maybe cancer centers and Medicare and Medicaid track is really important. And talking to your provider about, well, what can I do? How can I do this better? This is what's stressing me out right now. Because we might have some strategies, and we might also have some resources, what are called sort of supportive therapies, that not only us, but like our palliative care friends or our friends who work in the cancer psychology and cancer psychiatry group. I refer a ton of patients over there to have conversations about really the distress component of a cancer diagnosis.
I was pretty pessimistic about the possibilities of what might happen here after this morning, to be honest with you. I was feeling like, oh my God, why did I come here? Because the information was just like right in my face, and it just reminded me of everything I'd heard before and really knew but wasn't acknowledging day by day. But it was helpful just talking to people at lunch, and even though none of them were in my shoes diagnostically, it was still helpful. But I guess I need to try to get connected with people in my city. I'm from Salt Lake, so I'm probably the only one here from there. Anyone? Hey, what do you know? It might be helpful for me to just have a more informal group to talk to and be able to unload with people that really understand kind of the existential threat of it all.
Yeah.
Well, as I said in the beginning, BCAN.org is open 24 hours a day, 7 days a week. And I can promise you that anything that comes out of Dr. Sutka's trial with this team will be posted on our website, because we're incredibly proud of all of the work that we've done with Dr. Sutka over the years. This is not her first BCAN award. This is the biggest one, but it's certainly not her first award. And from the very beginning, we've seen that she's got so much passion about these aspects of bladder cancer that perhaps people that are more focused on just the technical aspect of caring for patients don't do. And we love to be able to support that, and it does work its way into everything that we do. And I thank you so much for stepping up and asking your question, and make sure you connect with the other folks from Utah so we can, wave your hands and make sure you guys eat dinner together or something. So where do you see 5 years from now? What do you, in the ideal world, what would you like BCAN to be promoting about what you have from all these studies?
I think the biggest thing that we're hoping, so we're really excited about the trial that we're running, but this is just a first step. It's a single center trial. The whole idea is, how can we create products that we can disseminate and make it something that's widely available? I think that the goal here is to really think about sort of all of the aspects of cultivating resilience. We talked about exercise. We talked about cognition. We talked a little bit about mental health. You're going to hear more about that next, and that's a really important piece. There's so many other things though, like nutrition, building community. So I think the work that BCAN does, where it brings people together to have these kinds of conversations, is really critical. I think our pie in the sky goal is to ultimately turn our trial into something that becomes a phase 3 and we can roll out across the country. But and I'll tell you, for example, I'm going to Paris in a month to go to the European Association of Urology, and we're giving a course on prehab there. That's the first time that's ever happened at the European meeting. We're going to do another one at the American Urologic Association. So we're trying to disseminate this knowledge because I think it's something that we've got to kind of open the conversation around this. We need to keep pushing the grounds on how we think about understanding the biology of this disease, understanding risk factors for this disease, and understanding our treatments and how we can make those more effective. We want to see that survivorship curve skyrocket. That's the goal. But at the end of the day, it's all about living with this disease or with what one is going through as a part of having that diagnosis and carrying it. And so we've got to make life good as it possibly can be. And so I loved, Hannah's doing some really thoughtful work at our cancer center trying to figure out how we can make it easier for patients to access these sort of supportive services and really kind of streamline that process. Take a lot of the legwork out of it, take down the barriers to accessing nutrition, physical medicine and rehab, cognitive and behavioral therapy that's appropriate. Like it's really about just taking a very holistic view. And so I think the work that Beacon's doing in terms of we're grateful for the support, but also just creating a space where we can have a conversation about all of this is so critical.
Well, I want to thank you all so much. This has been a phenomenal program.